Good morning. Thank you very much. It's a pleasure to talk to you about atrial fibrillation and heart failure. I'm going to try and focus in the next 10 minutes on key areas where concomitant heart failure impacts on the therapies that we might wish to give. In terms of my disclosures, the only one relevant to this is that I've received grants from companies with historic patents for beta blockers. So I think we're all aware of the problem that's going to face us in the coming decades. Both atrial fibrillation and heart failure will see substantial increases in prevalence, and that's because of an aging population. But of course, all our patients with cardiovascular disease are surviving longer to develop these conditions. And both, of course, we know are major drivers not only of healthcare cost, but also morbidity and mortality in our patients. But the group in between is probably less well studied. If you have heart failure, there's about a 30 to 40% risk that you will develop AF. On the converse, if you have atrial fibrillation, there's a third to over a half chance of you developing heart failure. And of course, no matter whether you look at randomized trials or observational data, the combination of both is bad news. So in our randomized data set, we found a 20 to 25% increase in mortality. It's even higher in the observational studies. And those data suggest that patients, even with preserved ejection fraction, are also at risk of higher mortality. So that, I think, is all well known, and I'll move on. But one important point is really hospitalization, because, of course, that's the key thing that's going to determine costs in our own countries. And if we look at the data from our randomized data sets, if patients have heart failure with the addition of atrial fibrillation, not only are they more likely to be hospitalized, but importantly, the length of their hospitalization increases. And we found a 2-day increase in all of these patients. What's the pathophysiology? Well, I'm not going to go into this because Barbara will take us through this, I'm sure, very elegantly in her talk. But as you know, the two are inextricably linked, and that is both the case for reduced ejection fraction as well as preserved ejection fraction. And of course, the link there is that there are structural changes, electrical triggers, neurohormonal activation, and then physiological and functional changes in both the atria and ventricles that makes both conditions very interdependent. In terms of the recent guidelines we worked on, we came up with sort of the 5 major treatment goals for patients with AF. Of course, some of those are to do with improved life expectancy, such as acute rhythm and rate control, risk reduction for cardiovascular disease, and of course, oral anticoagulation. And then, of course, the 2 relating to quality of life and functional improvements, including rate control and rhythm control strategies. So I'm just going to pick a couple of these where heart failure is a real problem for us. So you've heard lots, and of course this is what we're trying to prevent. So I'm a cardiac imager, so I feel the need to show you at least one imaging picture. But this is a 3D of a left atrial thrombus. Actually, I TOE'd this lady 4 weeks before this while she was in sinus rhythm, and the appendage was clear. And of course, if she'd gone on, this would probably have been a life-threatening stroke. And of course, we're all aware that heart failure is one of the CHADS VAS risk factors, potentiated importantly, as with the other risk factors, by older age. We know from the subgroup data of the NOAC trials that anticoagulation is probably effective in patients with concomitant heart failure. But of course, what happens afterwards is also an issue. And John's already gone through this, but essentially, you won't be surprised to hear that after you get anticoagulated, the risks of you developing ongoing risks of death or stroke afterwards are, of course, related to the type of AF, but also importantly, whether you have in red here pre-existing heart failure. What about rhythm control? Well, again, we're all aware of the AF-CHF trial. They showed, even in reduced ejection fraction patients, a very impressive reduction, a halving of atrial fibrillation over 2 years. But of course, despite that, there was no difference at all in cardiovascular death. And that's really comparing predominantly beta blockers with both amiodarone and cardioversion. I don't have time to go into the more detailed things, but essentially for ablation, and that accounts for both catheter and surgical, it is possible in reduced ejection fraction. And indeed, as you know, the studies in selected patients, selected centers, have shown that you can improve ejection fraction. But as you might expect, you lead to more complications in patients with heart failure, and there's a much higher recurrence rate of atrial fibrillation. What about rate control? Well, this is a big area of concern and one of my interests. We did a meta-analysis on this where we looked at every single study that ever published on digoxin versus control. It was 1 million patients in total, over 75 analyses. And as you see from the unadjusted observational data, it suggests that digoxin is associated with increased mortality. Now, this is in patients with heart failure, atrial fibrillation, or both. Any indication for digoxin. But of course that belies what we do in clinical practice. We're much more likely to give our sicker patients drugs like digoxin. And so when you start adjusting away for some of those differences, you start to get much more towards what the true facts are. And of course you end up with the randomized controlled trials, which of course they're only a small number, but show that there's a neutral effect of digoxin on mortality. I think this is an important wake-up call for us that we really should be careful about how we use observational data sets, particularly in conditions like AF, where we tend to, as clinicians, give patients specific treatments based on what our thoughts are as a clinician of their phenotype. The other important point is that in these heart failure trials in sinus rhythm, there were small but significant reductions in hospital admissions, and that, of course, is going to be important in our case, but we don't know whether that applies to patients with atrial fibrillation. There have not been any randomized trials. So if you're going to take that forward and then look at beta blockers, how do you do that? Well, we were very clear that we would not want to do it using observational data, and the only way of doing it successfully is actually to combine every patient that's put into a randomized controlled trial. And so that's what we did in the beta blockers collaboration. Over 18,000 patients in double-blind randomized trials, and that accounts for over 95% of every patient that's ever been randomized in these sorts of studies. What did we find? Well, you might expect to see this quite marked reduction in mortality in patients with heart failure and sinus rhythm. We saw a 30% reduction, and interestingly, that reduction was the same pretty much across the age range. And this is important, of course, particularly in our patients who are much older. But you can see there's a significant benefit even in the elderly patients who have a mean age around 80. What did we find in patients who had AF, though? Now, this is over 3,000 patients with heart failure, reduced ejection fraction, and AF on an ECG at the enrollment in their trial. Well, there we saw absolutely no benefit from beta blockers, and in fact, there's an equal number of patients who are benefiting as those who are harming, giving you an overall hazard ratio of nearly 1. So why do we not see a mortality benefit? This is, I think, is one of the big questions that I think we all need to work towards. I think it's helped by Isabel's great trial called RACE2, where you know this, that permanent AF patients were randomized to strict versus lenient rate control. And of course, the overall outcome of the trial was there was no difference in clinical outcomes, even when you attain a very strict heart rate. And that actually occurred in addition to the general group in the subgroup of patients who had clinical heart failure. Now, we've gone on to do some more work within our cohort of randomized data, and here you see the 14,000 patients in sinus rhythm. This is the relationship between heart rate at baseline and what happens to these patients as they go through these trials. And you can see that there's a very clear and linear relationship with heart rate in patients with sinus rhythm, but that does not happen in atrial fibrillation. So there's some disconnect happening here when you get atrial fibrillation and heart failure that means that the relationship between mortality and heart rate is somehow lost. And I think this is an important question that hopefully a lot of people here will start to work on. There are some other challenges, as you know, we have. So calcium channel blockers like diltiazem and verapamil, if you look at the subgroup data from the old diltiazem trials, you see that in patients with ejection fractions of 40% or above, actually diltiazem does not increase the risk of heart failure, even in those patients who have pulmonary congestion when they're randomized to these drugs. But on the opposite side, if you have an ejection fraction less than 40%, there's an almost doubling of heart failure on follow-up. So we have to be aware that this is an important interaction that will determine what happens to the treatments that we give. I'll mention diagnosis because it's another area of interest for me, but as you know, BNP is a major factor that we use now in clinical practice for diagnosing heart failure, both HFpEF and HFrEF. but BNP is consistently elevated in AF, and we do not know what the right diagnostic cutoff will be, and there's lots of work going on in numerous centres to look at that. Ejection fraction is one of my big bugbears because, particularly in atrial fibrillation, we have no data on whether these are valid and reproducible measures. And in fact, cardiac function and particularly stroke volume is very, very well linked to cardiac cycle length, and that's more so in AF. So finally, heart failure is a substrate for AF, we know that, and vice versa, but there are common comorbidities in addition. And when you have both together, there are worse outcomes, and as you've seen, probably less efficacy from the types of treatments that we're trying to give. But this conference is also about where we're moving on and new potential technologies. And one thing that we're doing in Birmingham is we've started the first randomized trial of beta blockers versus digoxin in patients with AF. And we're using some of that to try to help us integrate some new technologies. So, for example, better ways of looking at cardiac imaging, improving our reproducibility, enhancing with technology, patient education, and you'll see this later on this morning about the new ESC applications we've got for smartphones, as well as looking at computer enhancements and artificial intelligence and telemonitoring, in the end to try to create a more personalized approach, which hopefully also links in with the benefits that you've heard at the translational level to improving care of our patients. Thank you very much.